everyone. Welcome to Heart, presented by Arkansas Heart Hospital. I'm Vicki Wingfield, Community Relations Director, and I will be your moderator tonight. We could thank you all for joining us for a discussion about what else? Our heart. Our heart. It's a good night for a good discussion about the heart. I am delighted to have two very fine cardiologists with us, Dr. P.J. Flaherty, Dr. Hamza Reyes, and they are interventional cardiologists and graciously agreed to spend some time with me tonight to talk about heart disease. So I'm going to give the facts now, and I'm going to sound like Debbie Downer, but I promise you these are important facts. One person dies every 33 seconds in the United States from cardiovascular disease. 1 in every 5 deaths is from heart disease. In the United States, we are spending about $239 billion annually on the beast of heart disease. And sadly, we find Arkansas in the top 12 states with the highest rate of heart disease. We actually rank 9th on that list, with 12 being the worst. So this is not an untimely topic, and we need to start talking about the state of our heart. So we're going to do that tonight. We're going to have 3 segments tonight. We're going to talk about general cardiology, we're going to talk about diabetes, and we're going to talk about stress and the holidays. So hopefully in all of those topics, you're going to get a nugget or two that you can take to heart. And I meant to say that.
Perfect. No pun.
So we're going to get started. Dr. Flaherty, I'm going to start with you. How long have you been with us now?
Going on 20 years.
Going on 20 years.
2004, June of 2004 is when I, landed here.
And you came to us from military?
Yeah, and so I get a lot of strange looks because I moved here from Honolulu. That was my last stop.
What were you thinking?
I still haven't figured that out.
Well, I don't care where you moved from. We are sure happy that you call Arkansas home and call Arkansas Heart Hospital your home base.
It's almost too late to leave, I understand.
I get you. So we're going to talk basics. So tell me, what is a heart attack, Dr. Flaherty?
How long do we have?
You have 3.2 minutes.
Okay, yeah. By our definition, a heart attack is typically going to be associated with some obstruction to blood flow in a coronary artery. It's usually related to a rupture of a plaque inside of a coronary artery. Those plaques are generally comprised of cholesterol and all the other things that go along with it, white blood cells, platelets, and those type of things. And I usually will describe the plaques that we get in the coronary arteries as something analogous to acne, where you got a filled sac, if you want, with a lot of things like white blood cells, platelets, and the cholesterol and fat, and that type of thing, and it can grow very, very slowly over years, or it can suddenly show up and be very, very inflamed and then spontaneously rupture for whatever reason. They can do it by themselves. They can do it from changes in heart rate and blood pressure related to exercise and that type of thing. But the bottom line is that you get a sudden stoppage of blood flow, and that blood flow is delivering the nutrients. Typically oxygen is the one that we worry about most, and at that point, once that stops, it's just a matter of time until that clot either breaks down through your body's own natural enzyme pathways, or you have cellular death down at the end of the line there, where that's where we're typically talking about things we describe as a myocardial infarction. There's a lot of different things that people will talk about as heart attacks, and some of them are attacks of the heart that really aren't the same thing, but for the purposes of the discussion that we were getting into there, it's a lack of blood flow to the heart tissue.
Very good. So we typically identify those in a catheterization, which we lovingly know in our house as a cath.
Right.
Briefly tell us, what is a catheterization?
So that's how we make a roadmap of pretty much everything that's going on with the anatomy of somebody's coronary artery tree. And we can do it a couple of different ways. We have to find an artery that's got an open pathway to the heart, and we insert, we'll call it an IV, but it's really an intra-arterial line that we start that will allow us to run a plastic tube either up the arm or through the femoral groin arteries that will be directed under X-ray to the coronary arteries. There's two different coronary arteries, a left coronary and a right coronary. And that allows us to deliver a very controlled flow of contrast or dye that allows us to see on X-ray what's going on. So that contrast will replace blood flow for a very short period of time, typically a couple of seconds, allows us to see if the flow is wide open or if there's a sudden obstruction to that flow where there's a blockage. Then we can decide, what to do about that.
Is that still our gold standard for identification?
Right now, yes, and that's it's been that way for 40, 50 years now. CT scans are catching up to it, and there are some folks that are advocating using these to an extent in acute coronary syndromes, although most facilities aren't ready for prime time on that. You can come up with a scenario in which you come into an ER, you're identified as being at risk, they do a CT scan for you, and then they can stage interventions. If it looks like there's something that's blocked, you can pretty well have a good idea as to what you're getting into at that point in time. But if the CT scans are normal, then a lot of times we can re-triage them to something less severe or less acute.
Great. Dr. Reyes.
Yes.
Dr. Reyes is a new addition to the Arkansas Heart Hospital family, and we could not be happier to have another high-caliber cardiologist join our ranks. Dr. Reyes is a board-certified in cardiovascular medicine, critical care, echocardiography, nuclear cardiology, peripheral vascular imaging, and the cardiac CT.
My goodness, you're making us all look bad, man.
I know. So thank you, Dr. Reyes.
We have the experts here.
Did they warn you that they were going to throw you right in right away and get you started and get you out here? The first place we're going to put you is in front of a camera and a microphone.
I'm honored to be here. I'm happy.
We are
Yes,
delighted.
absolutely.
We're delighted. So I'm going to ask you, we're going to start talking. We know that risk factors are super, super important. So talk to us a
Absolutely.
little bit, Dr. Reyes, about how important it is to know our heart health history and the heart health history of our family.
Absolutely. So knowing your risk factors for heart disease, and if you have heart disease, knowing your risk factors for progression of your heart disease is very important, because preventing development of heart disease and preventing the progression of heart disease is absolute necessity, because it's easier to prevent it from happening than fixing it. And there are a lot of modifiable risk factors that we can work on as physicians and as patients to reduce the risk of having heart disease. A few examples are, for example, if you're diabetic, if you have hypertension, if you have a family history of heart disease, especially if your first-degree family member, especially your mom and dad, had heart disease at an early age. For men, that's usually 55 years of age. For women, 65 years of age. This is a strong family history of heart disease, and those patients we try to focus more on trying to focus on more exercise, lifestyle changes, diet, and also medical therapy. So we have some interventions in terms of cholesterol pills. Sometimes even aspirin is indicated in those situations even before you develop heart disease to prevent it from happening.
So it's very important to know, the holidays are upon us. We're going to be around some family members we may not have seen for a few years or a few months. It might be a really good opportunity to have a conversation to find out, hey, what is our family history? Because I'm a big proponent of knowing and having that information could just save your life. So thank you, Dr. Reyes.
Absolutely.
I think that's a great answer. Dr. Flaherty, when should I see a cardiologist?
There's really never a bad time. You were bringing up family history. I mean, if there is a first-degree relative that has coronary disease that's identified at an early age, and I think it's even earlier than what we were talking about a minute ago. If you see somebody who's got, early onset coronary disease, somebody who's at risk in their 30s or 40s, I'll usually try and back the next generation up by another decade. So, if somebody's been identified as having coronary disease in their 50s, a parent or so, I'll usually have the kids start looking in their 20s and 30s. So that's a little bit of a dodged question on that one, because everybody's going to be a little different.
Sure.
Certainly, if you're having symptoms that are even remotely typical of things that we were talking about, from a heart attack standpoint or the other related, diagnoses that we work with, there's never a bad time, and you would never want to tell somebody that they, were crying wolf or anything along those lines. I mean, we're here for an obvious reason, and that's to help people kind of work through some of those decision points.
I always tell my friends it's good to go ahead and establish a relationship, especially if that family history is there, to get a good on someone's radar now that can follow you, that you can always go to. So I'd agree with you. I don't think there's ever a bad time to get on a cardiologist radar.
Absolutely.
To make sure you can be seen and you have a relationship that you can tap into.
Yeah, it's always good to have a wingman. I mean, even if
Yeah.
you don't need one of us, I mean, having
Right.
somebody at arm's length or somebody that you
Right.
feel comfortable with calling,
Right.
that's always favorable.
I think so.
Absolutely.
Dr. Reyes, talk to us, Dr. Flaherty walked in and asked us when did it turn winter? Well, it has. December is upon us. Tell us about the impact of cold weather on the cardiovascular system.
Yes, I do have a very good experience on this. I spent the last few years in Midwest. And so the cold weather and the effect on the heart. So it actually puts a lot of pressure on the heart, especially if you already have a heart disease, because it will increase your blood pressure, and it will also cause spasm in the blood vessels that supply your your arm and leg, because the body is trying to preserve heat. And in trying to do that, it would cause spasm of those arteries. And so the heart's going to have to work harder to get blood there. So this put a lot of stress on the heart and will unmask any cardiac conditions. So if you have maybe a small plaque in the blood vessels that supply your heart, it might make it more evident, and you might feel some chest pain from that, and before you haven't had any stress from that. So being aware of this is is very important. Especially, in the cold areas, this happens when somebody is sedentary, not very active, and all of a sudden they are snowing outside. They go out to shovel the snow, and it's a very high intensity exercise, and the weather is very cold. So you're putting your heart under a lot of stress, and they can develop, heart problems during this. So that's why it's very good to be aware of that. That's a very good question. Yeah.
So being aware that there could be some issues, especially for already a heart patient, be wise
Absolutely.
when you get out there.
Absolutely.
We fortunately don't have to shovel snow here.
No, we usually have to
often.
shovel ice.
That's right. That's right.
Around
So-
here. Actually, it's an important thing that was just brought up there. That's the classic Norman Rockwell painting, is the older gentleman getting out, wintertime, doesn't warm up shoveling snow. It's just an, oh my God, I got to move this snow type of thing. And then it's the classic, bending over, holding his chest, the shovel's now on the ground. So that's an important take-home point. I think any of us who spent any time in medical school, that was one of the first pictures that was shown during our first year was, hey, this is one thing to look for.
Yeah, and it's a real deal thing. It's not just a Norman Rockwell picture.
Absolutely.
So, Dr. Flaherty, we know that risk factors are always a big deal when we're talking about. Can you talk to me a little bit about smoking and vaping?
Yes. So I'll start off with historically, we know from all of our data sets in cardiology and general medicine that smoking has all the bad things in it. I mean, it ranges from nicotine to tar to carbon monoxide to any other number of things that are in tobacco, insecticides, and then you light all that stuff on fire, and it's an instantly inflammatory process that happens. I mean, the minute somebody takes an inhalation of smoke, all of those things come together acutely, and that's an immediate cardiac risk factor. I mean, over time, there's more of a chronic process that goes on. So then the vaping aspect has been, brought up for the better part of the last decade or so in terms of whether or not it's got, a lesser risk profile than smoking does. And we've actually had some prior surgeon generals that have gotten on the boards of a variety of these different companies, interestingly, of which most, if not all of them, are, overseen in an umbrella fashion by big tobacco companies. So there's been this thought that you can transition from smoking to vaping and have, a no harm, no foul type of thing, and then it's a lower risk type of situation, which, when you factor out there's no tar, there's no, probably carbon monoxide issues and all of that stuff, yeah, maybe it is a little bit lower risk, but the nicotine is still there. That's a vasospastic property, and you can look at most people that are vaping, and most are hybrid users, and so they're smoking and vaping, and that then becomes a problem because none of them will tell you that they're actually still smoking. So there's risk with both. The vaping probably does carry with it a lower risk overall, but nobody's really ever studied the long-term effect of inhaling what basically amounts to theater fog, propylene glycol, and all of the aspects of heating a filament and that type of thing, which brings its own problems into the mix.
Well, we could probably talk for 2 or 3 hours on that topic. So
Absolutely.
But we have a question from one of our viewers, Dr. Reyes. Our viewer says, I have 3 stents. How many more can I get?
That's a very good question. But it have a lot of answers. It really depends on, the situation depends on which arteries, whether it's one artery, whether it's multiple arteries. So it really depends. I would say this question is going to be the best question you ask your cardiologist. If you don't have a cardiologist, we're happy to address that. Sometimes we need to put more than one stent to cover a big blockage, a long blockage. But that doesn't necessarily cover the whole artery. Obviously, we cannot put a lot of stents because otherwise you will block the flow to some of the small branches of the heart. But you can get more stents depending on your stress test, depending your ultrasound of your heart, depending on the coronary angiogram, the cardiac cath that Dr. Flaherty talked about. We take everything together. We look at your symptoms, and then we decide whether you will need more stents.
I know that you have both run across people with multiple stents, and some with just maybe one that's lasted them for a very, very long time. So it's a very individual and personal thing. You
Absolutely.
have to look at a lot of different things. So, well, we have covered a lot of information so far, all really good stuff. I told you guys these guys were sharp. So Arkansas Heart Hospital has 25 clinics around the state, plus our hospitals in Little Rock and Bryant. And that is notable because that means you may not have to come all the way to Little Rock or Bryant to be seen by a cardiologist. Dr. Flaherty, where do you go to see patients?
That's always a moving target, but presently we do the Little Rock main campus, Conway, Russellville, Danville, and Hot Springs.
Good, you are keeping that I-40 corridor hot, aren't you?
Yeah, I know where all the tire facilities
There
are.
you go, there you go. Dr. Reyes, where are you going?
So currently I cover the main Little Rock clinic, North Little Rock, and Harrison, and Mountain View.
Oh, they're going to send him north.
Yeah.
Whoa,
Yeah, you
there
think it's
go.
better here.
Yes.
So you can have outstanding cardiac care closer to home by some of our finest cardiologists in the state. You can find a listing of our physicians, APRNs, and clinics on our website, arheart.com. We're going to take a quick break, and then we'll be back. We're going to talk about diabetes in your heart. So we'll be right back.
Perfect.
Your heart is special, and it means everything. Your heart moves you, motivates you. Sometimes it skips a beat. Sometimes it stands still. Your heart is important. It's powerful. And something this special deserves specialized care.
The choice is yours. Choose the only hospital in the region dedicated entirely to your heart, Arkansas Heart Hospital.
Can cayenne pepper and vodka stop a heart attack? Can stress cause one? Do garlic and cloves really fix high blood pressure? See fast takes and real talk from the experts at Arkansas Heart Hospital.
Why would our second hospital focus on bariatric surgery?
Encore Medical Center is home to our Bariatric and Metabolic Institute,
where we take a whole new approach.
Losing weight for heart health.
Here, we help patients reach their weight loss goals, reverse diabetes, and improve their quality of life.
Encore is our second act. Let's get started on yours.
Learn how weight loss can help improve your health with tips and tricks for healthy eating, managing obesity, and much more. All from the weight loss experts at Arkansas Heart Hospital. Debunk common myths about heart health with our panel of cardiac experts. From COVID to heart disease and beyond. Ready to learn something new? Watch now.
Your heart is special, and it deserves specialized care.
The choice is yours. Choose the only hospital in the region dedicated entirely to your heart, Arkansas Heart Hospital.
I hope you called someone you know who's diabetic and told them to tune in. If you're diabetic or you have a family member who is, turn up the volume or your hearing aids, because we're going to talk about diabetes, and it's a really important topic. So November is National Diabetes Month, and did you know that 2/3 of our diabetic friends will develop heart disease? It ravages not only the cardiovascular system, but other vital systems as well. We actually have a pandemic. We've already had one of those.
Yeah, be careful with that.
Be careful with that. We have an epidemic of diabetes in Arkansas. 13.9% of our population is diagnosed as diabetic. 34% of our population has been determined to be pre-diabetic. And we've got about 70,000 people wandering around who don't even know they have it.
Right.
So I've said it again, we have an epidemic. So before we turn into this, we had another question come in real quick on the cardiology, general cardiology. I want to make sure we answer. One of our fine doctors, and you can just tell us who those fine doctors are. We always love to know who they are. Just found out a widowmaker in my left LAD and stented. Can you tell us about the cardiac rehab program we offer? Either of you want to talk a little bit about cardiac rehab?
You know, this is probably one of the best things as an institution that we offer. And I've never really seen, in my own personal experience, you know, a place that has this as front and center in our management strategies as this one does. And really, you know, what we're doing is trying to manage some of the background risk factors that got folks to there in the where they are in the first place. But it allows them to feel a little bit more empowered in terms of being able to manage things and understanding through constant feedback, you know, what their limitations are and what we're striving for as their goals moving forward. Hopefully, we're going to see a lot of improvements in the things that, you know, got folks to where, you know, they found themselves when they first found out they had coronary problems, but trying to identify things that we can do with their diet, things that we can do with their exercise. And there's almost no one who can't do some form of exercise. We can almost accommodate everybody in some capacity along those lines. We'll look at things like body composition, dietary maneuvers that can be made. There's cooking classes, there's stress management classes, there's all kinds of different wellness you know, programs that we can get folks plugged into. This is different than regular, you know, just cardiac rehab where you'd go in and do a little physical therapy and exercise and walk on a treadmill for a few minutes. It's a very comprehensive program that's called intensive cardiac rehab, and there's only a handful of these in the state of Arkansas that are able to do this, and I think we have 4 of them now, right?
4.
So we wholeheartedly advise that in pretty much anybody who seeks our services. We just plug them in for these things after the fact to try and help them moving forward.
It is indeed a great program, and you do not have to have been a patient at Arkansas Heart Hospital to participate in our cardiac
Correct.
rehab program. If you have a need, we'll help identify what you need to do, and we would love to be a part of that conversation. So you can put in your comments if you'd like some more information on that, and we'd be happy to contact you. We've got another question, and listen, we love your questions, so please ask them. We are totally ready to divert anything we've got already written down to answer your questions, so thank you. Don't be shy. Dr. Reyes, I'm going to let you take this one. Everyone on my paternal side has passed due to heart disease. Diabetes on mom's side. I am 44 years old with controlled hypertension. I have since lost weight. I'm active, eat clean for the most part. What are my chances of having extensive heart disease? What a great question.
That's an excellent question. And first of all, you're in the right path. You have your blood pressure controlled, you're losing weight, you're being active. You're doing all the right things that anybody should do, but especially somebody who have strong family history of heart disease. So in addition to this, sometimes when patients have very high risk of heart disease because of family members having strong history, we recommend sometimes to watch your cholesterol. So you need to check your cholesterol, and based on the cholesterol level, we might need to put you on cholesterol medications. And you also might need some other additional screening tests. Based on them, we might need to do to give you aspirin as well. So you are on the right path. I think the most important things you're doing, but there might be some additional testing and additional assessment that's needed to see if we need to do more further medical interventions to prevent you from having any heart disease.
This is, I think, one of those good examples of someone who may not be diagnosed with heart disease at this point, but probably could stand to have a visit with a cardiologist, be on someone's radar to make sure that they know where they would go if and when they got that, just to help them monitor and watch that. So,
yeah, this type of familial coronary disease type of thing usually has something to do with a genetic dyslipidemia profile. And there's a lot that we can look into as far as that goes, because it's not always going to be in the number. It's in the construct of the LDL particle, which is your bad cholesterol. There are different patterns. There's apolipoproteins to be looking for. There's inflammatory markers to be looking for, and how these things all kind of function as the key and the ignition switch, and how they come together is going to be unique to certain families, but there are certain patterns that cluster together that can raise somebody's risk. And in this type of situation, I would certainly be looking for a fairly extensive lipid analysis. And it's kind of an exciting time from a lipid management standpoint, because for the last 30 plus years, we were kind of stuck with statins as our only thing. And there's a lot of progress that's being made over the last 5 years or so in other agents that we can use. And the next modification is going to be RNA and DNA modification of the cholesterol particles in the level of the liver, such that you come in and get from time to time interval infusions of an agent that might take care of the situation either permanently or semi-permanently. So that's kind of next frontier stuff, but it's coming.
Wow. Yeah, like you said, we've been kind of stuck in this one mode of treatment for such a long time, and we've got so many people that just can't take the statins.
Correct.
So what a neat thing for us to be able looking at other opportunities and options. So let's talk a little bit about diabetes, since it is such an important, and it is a risk factor. We know that so very many of our diabetic friends are going to end up with some kind of heart disease. So Dr. Reyes, what is diabetes?
So diabetes is a chronic disease, it's a chronic condition, so a long-term illness that basically the body cannot control the blood sugar. Usually the blood sugar is controlled by insulin, so either your insulin is very low, and that's type 1 diabetes, or you have a resistance to insulin. And I like to call the diabetes the killer, the silent killer, because it's a disease that have very mild symptoms, especially in the beginning, and the symptoms of diabetes can be a lot of times overlooked, and you cannot realize you have it. As you mentioned earlier, 70,000 people in Arkansas probably have diabetes and they don't know, but it will still exert its effect, the deadly effect on every system in the body, but especially the heart. So it will affect your brain, can cause strokes, can cause vision problems and even blindness. It can affect the blood vessels of your leg, lead to ulcers and potentially amputation. The guts, your digestion. In the heart, it can cause disease of the blood vessels that supply the heart, and in a very characteristic way. And so, like smoking, regular atherosclerosis or narrowing of the vessels from aging usually causes focal disease, but diabetes usually causes really diffuse disease that's very challenging to treat. And when we find that a lot of times putting a stent is not enough. You sometimes have to do an open heart surgery and bypass surgery. So that's why I call it the silent killer.
So how do you and your patient base, that's a heart patient already, and also a diabetic, how do you take care of that patient?
That's been an evolving topic as well, and similar to the cholesterol management strategies, we've seen a lot in the last 5 years of management strategies that have been very cardiologist friendly. With the advent of some of the medications that come from a class called SGLT2 inhibitors, Jardiance and Farxiga being the primary ones that people would have heard of, as well as the newer injectable medicines, Ozempic and Mounjaro, that are called GLP-1 agonist or antagonist medications that directly impact not only the diabetic component of things, but by extension, the cardiovascular risk that comes along with it. This is the first time we've really been able to, have something that's translated into the end point here. Historically, the medicines that we thought might reduce somebody's risk of cardiac events, but these medications are being shown to do it independent of whether or not these folks have diabetes. So we know that there's direct cardiovascular benefits. So I think most cardiologists, including myself, are starting to feel a lot more comfortable about being the frontline prescribers of these agents. So, first thing I'll usually do is, let's face it, most of our folks are going to come in overweight. Right. So we'll have a discussion about what that means. We'll have a discussion about insulin resistance. We'll check fasting glucose levels. We'll check markers for insulin resistance, hemoglobin A1Cs, to kind of see how they've been doing for longer periods of time. And if need be, we'll have that hard discussion about, if it's not hurting you now, it's going to hurt, if not kill you and shorten your life later on. And sometimes that's what you've got to frame it as so that you get their attention, because as you were saying, this is kind of the silent killer. It's a, out of sight, out of mind thing. And nobody ever died from diabetes because they were too sweet. It's because of the end effect of what goes on with it. And so I've taken a much more aggressive stance on this than just passively sending it back to, somebody's primary care physician or their endocrinologist or what have you. And I say, look, this is potentially urgency or an emergency for you to get a hold of this. Again, this might not be a next week or a next year type of thing, but if you're 45 years old, this is something that could potentially shorten your life expectancy greatly. And we're already seeing that in the current generation. Our kids are now expected to have a shortened life expectancy compared to us, and that's the first time pretty much in the history of modern medicine that that's been seen. And it's directly related to these topics.
Listen, medicine and the great things that are going on, it's truly exciting that we can look at things we've not been able to look at before, and you've been able to take a more a more comprehensive stance for your heart patients with all these other things that are also comorbidities and risk factors and things like that. So while tough discussions, still an exciting time. We have another audience question. 52-year-old that recently had a stent. My question went away.
How long is the recovery period?
Hold on, there it is. 53-year-old female diagnosed with CAD and familial high cholesterol, recently had a stent placed. How long is the recovery period? Dr. Reyes?
Yes. So the recovery period really depends on the procedure, the complexity of the procedure, whether they went through your wrist or through the leg artery, the groin area. But in general, usually you should restrain from, heavy physical activity, lifting heavy weights, especially if they went through your wrist for the first couple of weeks. If you're having, the way. What I tell my patients is if you are exerting yourself and you're feeling it, you have chest pain, you have shortness of breath, you feel you pass your limit, just back off a little bit, slow a little bit, and give yourself more time to recovery. And this brings us to a discussion we had about cardiac rehab. So cardiac rehab is one of the best ways of recovering after having heart disease, heart attack, having a stent. And it's not only an exercise, it's an exercise that have been proven to really improve your risk of having another heart problem, having stent problems, and having readmissions from heart disease. So it's very beneficial, and you will have a team that's really expert on this, and they will guide you on your recovery.
You brought actually a very interesting point in there. We have a lot of patients who come in here and in our clinics, and they're notoriously skeptical about medications that we give them, and they automatically jump to the conclusion that somehow or another doctors are in cahoots with big pharma. So if you want to back that up a little bit, there is one proven strategy out of all this stuff that can take care of all this, and it's exercise. Exercise is the magic bullet in a lot of this stuff, such that if you manage, your glucose or glycemic index, your blood pressure, your weight, all of this stuff, that makes these medications and all these folks that we're in cahoots with go away.
Yeah.
So that's an important point that I wanted to kind of emphasize there.
I'm glad you added that. So you guys are rock stars. You are nailing it tonight. So I love that we can throw any question to you and get a terrific answer. So we're going to stop for just a minute. We're going to give these guys a chance to have a drink, water. And you go grab some water too, and we'll be right back.
Your heart is special, and it means everything. Your heart moves you, motivates you. Sometimes it skips a beat. Sometimes it stands still. Your heart is important. It's powerful. And something this special deserves specialized care.
The choice is yours. Choose the only hospital in the region dedicated entirely to your heart, Arkansas Heart Hospital.
Can cayenne pepper and vodka stop a heart attack? Can stress cause one? Do garlic and cloves really fix high blood pressure? See fast takes and real talk from the experts at Arkansas Heart Hospital.
Why would our second hospital focus on bariatric surgery?
Encore Medical Center is home to our Bariatric and Metabolic Institute,
where we take a whole new approach.
Losing weight for heart health.
Here, we help patients reach their weight loss goals, reverse diabetes, and improve their quality of life.
Encore is our second act. Let's get started on yours.
Learn how weight loss can help improve your health with tips and tricks for healthy eating, managing obesity, and much more. All from the weight loss experts at Arkansas Heart Hospital. Debunk common myths about heart health with our panel of cardiac experts. From COVID to heart disease and beyond. Ready to learn something new? Watch now.
Your heart is special, and it deserves specialized care.
The choice is yours. Choose the only hospital in the region dedicated entirely to your heart, Arkansas Heart Hospital.
And we're back. Are you all hydrated and ready to hear from a little more from Dr. Flaherty and Dr. Reyes? Me too. So here we are. It's holiday season yet again. And this can be a great time of year, no doubt. But it also can bring some additional stresses into our lives. The level of activities on top of an already full schedule, events packed with foods we don't normally eat, gatherings with people that may cause discomfort. It all adds up to stress. So over 25 years ago, when I first started educating in the community about heart disease, a shameless plug for myself, I love to speak to groups, so y'all call and let me speak to your next group. I would love it. We would talk about stress, but on my list of risk factors, it was really near the bottom of the list. But it has really climbed the hit parade over the last few years, and I look at it in the top 5 now. That stressors can really have some impact on the cardiovascular system. And Arkansas was recently ranked as the 4th most stressful state, which I found that was very interesting. So we want to talk a little bit tonight about the heart-stress connection. So Dr. Flaherty, talk to us a little bit about what that might look like.
Yeah, I mean, it's been well known for a long time, but probably under-evaluated, under-treated, underappreciated as to how much stress does really contribute to not only things like heart attacks, but just the progression of coronary disease in a lot of different ways. Getting to back to your original point about the holiday stress and that type of stuff, one of the biggest things that that this time of year can do is knock people off their routines. So you're traveling, you're eating things that you wouldn't necessarily eat, you're spending time with people that you may or may not have normally been spending time with. Alcohol consumption tends to go up some, exercise tends to go down a lot, sleeping patterns get thrown off, and this sets off a cascade of bad events, raises levels of inflammation, directly impacts glucose metabolism. Stress alone can do that, but so can sleep disruption, so can being angry at somebody or getting into intense conversations and those type of things. But stress long term is counterproductive to virtually any aspect of health that you could look at, and cardiac issues are just one of the examples of things that can get thrown sideways on that. And so I'll try to, obviously we can't really control somebody's stress. We can give folks some gentle nudges in certain areas just to try and help them with identifying areas that they might be able to help with themselves with some self-care, taking time away from the environment that they find themselves in, even if it doesn't have anything to do with the holidays or anything like that. Just kind of taking a moment to dial it back a little bit and kind of recenter and refocus on just some healthier things that they may be able to do for themselves, even if it's just taking a minute to meditate or go for a walk or just think about things a little bit more.
Yeah, and everybody has different responses to stress for sure, and how we manage it and what we do with that. Dr. Reyes, what are some symptoms that someone might experience that would be might be triggered by a cardiovascular experience? What might someone experience?
Yes. So symptoms of having a heart problem, they include usually chest pain. You'll have it like chest pressure, like feeling somebody sitting over your chest. You will see some patients who have a heart attack. They will tell you, I feel like an elephant sitting over my chest. And then they might have this pain or this pressure climbing into their neck, shoulder, arm numbness, going to the back. Some patients might have some shortness of breath. Suddenly they feel short of breath. They feel their heart is racing, especially if this lasts. If chest pain, very mild chest pain that lasts for a second or two, goes away and you never have it again, that's usually nothing that you need to really stress yourself about, unless you have diabetes, hypertension, and other medical problems. But if you're healthy in general, if you have chest pain, just lasts for a second or two and it goes away and doesn't have some of the typical features that I just mentioned, you don't need to stress yourself about it and enjoy your holidays. But one thing I want to mention is that some patient categories, like women, diabetic patients, and heart transplant patients, they tend to have atypical symptoms or symptoms that are not, textbook symptoms of heart attack. So their chest pain is not going to be that pressure I mentioned. It might be just some discomfort. Some of them have belly pain. Some of them will have some arm numbness only, with no chest pain. So you need to be very vigilant, especially if you're diabetic, because the nerve supply to the heart, to the whole body is affected by diabetes, and your ability to sense that you're having something wrong with your heart cannot be very accurate, and you cannot rely on that. So you need to have a lower threshold, to seek medical attention and talk to your doctor.
Dr. Reyes, how would we distinguish a heart attack from a panic or an anxiety attack?
Excellent question. So sometimes it's hard to distinguish, and if usually a panic attack, it's usually you'll have a constellation of symptoms. It's not only the chest pain, and not necessarily starts with the chest pain. So you will have, your heart's going to be beating fast. You might have the chest pain, but you also will feel very anxious. And usually there is a trigger, but there is a lot of overlap, and you should not put yourself in a position that you have to discern whether this is just an anxiety or this is just a cardiac condition. Seek for help, ask for help. We look at a lot of a variety of things. If it's somebody who is very young, doesn't have family history of heart disease, a 20-year-old male or female who doesn't have diabetes, doesn't have hypertension, doesn't have family history of heart disease, going through a lot of stress in school or in the job, and is having those attacks in which he sweats a lot and have the heart beating very fast, and then it goes away. But otherwise, exercising very well, playing soccer with no issues at all, not short of breath doing exercise. But when he's at rest and he gets stressed, he have this sudden episodes, but otherwise he's doing fine. Then this is probably not a heart attack. But if you're diabetic, if you're hypertensive, and if you start walking, every time you walk or you run, you start to have this chest pain, this chest pressure, and your heart starts racing, then this is probably a heart disease.
So you can always seek help. You can always ask
Absolutely.
for help. We would
Absolutely.
rather you come get some help and us say everything's fine, it's just an anxiety attack, than to be having a heart attack and not recognize it. So
Absolutely.
get help. We'd rather send
Absolutely,
you home
and
okay than
it's always an opportunity to do some screening and
Yes.
primary prevention.
Yes.
It's highly recommended to at least check your blood pressure. Even for very young people, to check your blood pressure every year or so, to check your cholesterol at least once, even in young people, because this way you can pick up any genetically inherited diseases early on, or any heart disease that might not been diagnosed before, and also to prevent anything from happening in the future.
it's always good.
Yeah.
Yeah, it's you brought up another interesting point there. It's important to follow patterns on these people. So if you've got somebody who's in their 40s and 50s and has never previously been labeled with an anxiety disorder or panic attacks or anything like that, the likelihood that that's just going to be the first thing you jump to as a consideration is probably a little bit lower on their list. And I can't think of a cardiologist who would ever go to that one as their number one thought. in somebody who didn't previously have a diagnosis of an anxiety disorder. That's almost exclusively going to be a diagnosis of exclusion from our standpoint. That doesn't necessarily mean that's not what's going on. But if you've got somebody who has a lifelong history of panic attacks, panic disorders, and that type of thing with no other real significant cardiac risk factors, then you can feel a little bit more comfortable with.
That's good. All right, we've got about 5, 6, 7 minutes left, however long Mr. Producer will let me play tonight. So I want to do something fun.
Oh boy.
We've been having fun. You've been having fun?
Yes,
Like this hasn't been
absolutely.
fun. Come on, we've been having a blast. I want to play rapid fire. So I've got about 6 or 7 statements that I'm just going to make a statement, and I want either one, you jump in. If I had a bell, I'd make you ring a bell, but I don't have
It's
one.
Family Feud.
It's
All right,
Family Feud.
gotcha.
It's Family Feud. All right. So I'm just going to make these statements, and you just tell me, and it can be a quick answer, a short answer, whatever. So, heart disease does not run in my family, so I don't have to be concerned about it.
False. It makes you feel a little bit better when the family history isn't there, but we've got legions of people that have no significant family history that can be at risk. There's this old adage that we learn in medicine is that 75% of people who have lung cancer are smokers, but 75% of smokers are never going to have lung cancer, and so you just can't take that one variable and say, I don't have X, Y, Z. So, and the same holds true for coronary disease.
All right. Come on, get ready. Anger can cause a heart attack.
Yes.
Tell me
So
why.
if you have the predisposition, if you have heart disease that's dormant, and still covered up, and you have a sudden stressing event, and being angry all of a sudden, this will drive your blood pressure up, this will drive your heart rate up, and this can unmask any heart disease that you have, and you can develop a heart attack from that. And also stress, the stress of anger you can cause enough inflammatory reaction, and if you have already some plaque in the blood vessels that supply your heart, this can rupture, and you can have a sudden blockage in the vessels that supply your heart, and this is basically a heart attack.
All right. Drinking more than 4 cups of coffee a day raises my risk of a heart attack.
Oh my God, this is one of the most controversial topics in cardiology, and you're going to hear a different answer depending on what paper it is that you've read in the stack of 100 papers that are readable on this
Whether
one.
you like coffee or not, right?
Bingo. I mean, you're going to get things that are sponsored by the coffee industry, and you're going to get things that are sponsored by the tea industry, and you're going to get things that are sponsored by the wine industry on this. I don't know that I have seen a definitive conclusion on this one, and I don't know that in the history of mankind that we will ever see a definitive evaluation on this. Now, one of the things that we do know is that heavily caffeinated beverages can increase your risk of arrhythmias, and so we've all kind of lived through this problem with the energy drinks, over the last decade or so, and we'll hear about these odd, deaths of young people when they, ran through a case of Red Bull or Monster or any of these drinks. So, what you're alluding to with the coffee, I mean, if that was the case, I'd be dead by now. But be that as it may, I mean, this is one of these things. Is moderation is the key on any of these things.
Yeah. All right. You ready for this one? You're going to really enjoy this
Great.
one. Being short increases your risk of heart disease.
I'll let Vicki answer that.
Did I stump you? I actually, I'm so excited. I actually have the answer to this one. As strange as it sounds, there's research.
I know.
Research has been funded that says genes which predispose us to being short may make us more likely to suffer from heart disease.
Yeah.
Did you know that?
I heard about this before.
Yeah.
Did you know it? Look, I told you these guys were super sharp.
This is not one of the ones where we walk into the room and we see somebody who's 5 foot tall and say, "Oh, you've got problems." I mean, so theoretically, yeah. I mean, there may be a statistical link, although how strong that is, it's not on our list of risk factors.
Well, that's good because my little 5 foot self went, what?
Right.
So that's good. You guys have been great. So one last thing I want you to say. Dr. Reyes, what's the best holiday tip you'd like to give your patients?
the best tip I would give is, holidays are great times, but, as we mentioned, you'll have to rush, you have to travel, you might miss your medications at home after you travel, or forget your medications. Just try to enjoy it, enjoy your time, and but it's a good opportunity. It's a good opportunity when all the family is around to talk about health. Especially if you have young people around. If you have teenagers, talk about the effects of smoking. The bad effects of smoking. Talk about healthy diet. This is a really good opportunity to put some good habits in the young generation, because those habits are the ones who are going to prevent them from having heart disease, diabetes. So I think taking advantage of those family gatherings to talk about those things are very important.
What about you, sir?
I like everything that I just heard. I think I think staying on routine and having a plan for those times where it may be more difficult for you to stay on routine, planning ahead, making sure you have ample supply of medications. If you're traveling, everybody wants to keep their stuff as organized in as one place as possible, but particularly if you're checking luggage and have the ability to take a carry-on, having an extra couple of days supply of your medicines in your carry-on if your luggage were to get lost, that can save a lot of people a lot of hassle. As I said, it's just having a plan, knowing when to say when, in terms of what you're doing with your diet, what you're doing with how much you're drinking, what to do with the time that you're spending with people that you may not be used to being around. These are all very important things just to help you get through that couple of weeks. This is basically a month from Thanksgiving to the end of December that people have to be kind of working through this. And we do see an increased rate of cardiovascular events between Thanksgiving and the Christmas and holiday period. And there's a lot of things that factor into it, but a lot of it's just that people are doing things differently than what they would normally be doing. We have something that's called holiday heart. We know it. We know that that's related to the cardiotoxic effect of just overindulging in alcoholic beverages and those type of things. And people deserve to cut loose a little bit and spend time and have a good time, but you have to do it with some degree of awareness about you, and make sure that you just take care of yourself.
Gosh, you guys have been terrific. I have a couple of resources, Mr. Producer, if you'd put them up on the screen. If you are hypertensive, we want you to make sure you're monitoring that. So we have a blood pressure log that if you would like to have a copy of that, we would love for you to just drop it in the comments. We'll get it to you. And then we also have there's a little bit of football left, Dr. Flaherty, just a little. And we've got a heart attack game plan that if you'd like to get a copy of that, put it in the comments. We'll make sure we get that over to you. Just a couple of things for you to have as you move through the holiday season. So you can find information about all that you need about our physicians, our APRNs, our clinics, our programs, our services, jobs, any of that on our website, arheart.com. Remember, you are your own best heart care advocate. You're your best friend when it comes to your heart health. Happy holidays. Take care of your heart. And with that, we're out of here, and we'll see you next time.
Thank you.
Thanks very much, Vicki.